Welcome to today's webinar from the International Alliance of ALS and MD Associations, which is the Mid-Year Scientific Advisory Council update and Q&A. And it is also a very important day, June 21st, Global Awareness Day for ALS MD. For this webinar, we have English and Spanish captions available. If you are joining us live on Zoom, please check the chat box as we are adding the instructions right now. And if you are watching the recording in our YouTube channel, you will find the instructions in the video description on how to activate the subtitles. Para este seminario web, tenemos subtítulos en inglés y en español disponibles. Si se unen a nosotros en vivo vía Zoom, verifique la casilla del chat, ya que estamos agregando las instrucciones en este momento. Y si está viendo la grabación en nuestro canal de YouTube, encontrará las instrucciones en la descripción del video sobre cómo activar los subtítulos. Thank you to our sponsor, Biogen, without whom this webinar series would not be possible. For those of you who don't know me, I am Jessica May, the Programs Coordinator of the International Alliance of ALS and MD Associations, and I'm joined today by members of the Alliance's Scientific Advisory Council. Before we start, I want to highlight our Advisory Council as a whole. They are a fantastic group of experts that work with the Alliance throughout the year to provide us with evidence-based information that we can then share with the public and our member associations. The chair of the council as of the beginning of this year is Dr. Gethin, Executive Director of Research in MD Australia, and who will be moderating our webinar today. In the screen, you can see the full council and our board liaison, Pablo Aquino from the ALS Association in Argentina. Joining Gethin in the panel are Dr. Nadia Sethi from the United States. She works for the ALS Therapy Development Institute as Director of Community Outreach and Engagement. In this role, she shares information about approved and investigational treatments, clinical trials, and research with people living with ALS and their families. Nadia lost her husband to ALS and has been involved with many advocacy efforts to support new treatments since his diagnosis in 2019. Dr. Kuldip, also from the United States, is Vice President of Research at the ALS Association. He's the former Director of Research Programs at the Michael J. Fox Foundation for Parkinson's Research, where he worked for 9 years developing and implementing the Foundation's ambitious research vision in the biology of Parkinson's. Dr. Nicholas Cole from the UK is Head of Research for the MD Association. Dr. Cole started his own lab in the University of Sydney modeling ALS MD in zebrafish and helped establish the MD Research Centre at Macquarie University in Sydney. Nick returned to the UK to take up his position as Head of Research at the MD Association in 2018. And Dr. David Taylor from Canada, whose role at ALS Canada has been to oversee and advance the Canadian National Research Programme. In this capacity, he provides strategic expertise, advice, and direction to all stakeholders of the organization and strives to communicate all ALS research in an accessible and understandable manner. Now, some final instructions. Any questions you have for our panel, please write them in the Zoom Q&A box. And if you're watching from Facebook, you can add your questions in the comment. I also want to take this opportunity to thank everyone who submitted their questions. There is a lot to cover, and we will do our best to answer as many questions as we can in the time that we have. I will now turn it to Dr. Gethin, our moderator for today.
Thank you, Jess. And thank you to the Alliance for inviting me onto the panel this evening or this morning, wherever you may be. And thank you to my fellow panel members as well for coming along today. One thing I just will note is that we don't actually have a clinical neurologist on the panel tonight. So some of our answers to any specific clinical questions may be a little more generic, as we may not have that specific knowledge around treatments or clinical questions. So just to kick it off tonight, I'd just like to go around the panel and just ask people what they have, what is the best thing they've come across in the MND ALS research world in the last 6 to 12 months? Just what has really sort of, have you seen as a big improvement or has really caught your attention? I'll be happy to lead it off. And one of the best things I've seen is the increasing voice and the increasing cooperation with people with lived experience. We're hearing it louder and louder. And we're really seeing it perhaps in, say, clinical trial design, and even considerations around research. Certainly it's happening here in Australia very strongly. It's certainly engaging more and more with the lived experience community, and it's really, we're seeing obvious benefits in what we decide to do and how we do it, and getting very clear messages about how we communicate with people with MND, ALS, and what they expect from us. And to me, that's been really, really educational and really beneficial. I'll just flick it on now to Nadia, who's top of my screen.
Hello, everybody. Yeah, so I think there have been so many readouts in the last year. It's actually hard to keep up with them, right? So I feel like we're getting a lot more answers, even in the short time that I've been in ALS world for the last 4 years. There's just been a lot of new information that's come out in the last year. And I think that speaks to a lot of the efforts, again, from the patient and caregiver community in pushing for more answers quickly. And there's just so much innovation that's happening around the world, all these platform trials that are occurring and collaborative efforts. So I'm really excited to see that there's been just so many answers that we're getting in the last year in ALS treatment.
Thank you, Nadia. Dave?
I should look at Nick to ask, were you going to do experts? Or was that not the one you were going to talk about, Experts ALS, which just got announced this morning? I'm really excited about it from the announcement this morning, but I don't want to steal it from you.
No, it's fantastic. You go for it.
Okay. So just this morning, actually, there was an announcement as the first initiative of the UK MND Research Institute about a platform that actually one of our colleagues on the SAC, Professor Chris McDermott, is a big part of. And they're going to do something really different. As I understand it, it's still early days and I haven't maybe got the full breadth of it, but really using neurofilament and biomarkers as an opportunity to be able to look for therapeutics in ALS that might be more along the lines of home runs, things that are going to preserve neuronal health and actually try to find out what those could be in a quick fashion so that you could find something that you'd really want to double down on with a pivotal trial and try to ultimately look for those things in a faster manner than we've been doing in the past. It doesn't mean that we won't be doing things still the way that we're doing them. It doesn't mean that, therapies that don't change that particular biomarker won't still be explored in ALS MND. But I think it's a really bold move to be able to look for therapies that might be able to actually rescue neuronal health. And I think that's pretty exciting. And it's, as of this morning, I think first time public. So I'm super excited about that, but lots of things exciting in the world.
Great. Thank you, David. Nick?
That's great. Thanks, David. I was just going to add to that. There's a fantastic podcast, 2-part Create podcast on that Nadia has done recently, which is really worth listening to. There's a lot of explanation in there. So that really brings me on to, my real excitement. In the UK, we've managed to pull together, it's not perfect, but with the government, a fund of money, United to End MND campaign, which has been pulled together by people living with MND, the charities in the UK and others. And that sort of money and seed funding has really led to a number of initiatives, and we've leveraged quite significant funding, and some really incredible projects are coming off the back of that. So that's been a really a great step, and hopefully a step change for us in the UK. And also we're in a position now where we've got 8 clinical trials ongoing in the UK, so more trials than ever before. In terms of research grants that we're funding, we have 113 funded by the Motor Neuron Disease Association, which is more than we've ever had before as well. So, really optimistic that things are changing and we're moving in the right direction. So yeah, fingers crossed we'll see some promising and effective therapies coming through.
Great. Thanks, Nick. Kuldip.
Hi, everyone. This one is easy. We had 2 drugs approved in the last year, Relyvrio and tofersen, and this is really, really exciting. Think about waiting, 100 years before getting Riluzole, and another 20 years before Radicava was approved. And now in the last year, we had 2 drugs approved. And I think beyond that, or reading through that, is the fact that the FDA, at least here in America, is looking at regulatory flexibility. That ALS MND is not a disease like allergies or asthma, or even diabetes or cancer or heart disease. That this is a unique disease, that it has a rapid progression, and that FDA and other regulatory agencies need to be flexible when they are looking at scientific data. They need to be rigorous when they look at scientific data, but that don't use a different lens when they're looking at drugs that are treating ALS. And so I think that's really the exciting part, that FDA, for example, looked at neurofilament light as a surrogate biomarker for approval for tofersen. That's really exciting, and it gives an opportunity for other companies to take their drugs forward.
Thank you, Kuldip. I think there's a really big theme coming through there, one of lots of breakthroughs and moving forward in the last year, and that everyone's working together, I think, a lot better than they used to really help push things faster and forward. So now I'd just like to move us to some of the questions that we've had sent through people have sent through in advance. So first question up is approximately 5% of people live for over 20 years with ALS. So what studies are happening at the moment as to compare people who are perhaps they're fast progressors versus slower progressors, and how are those studies going around the world? And perhaps if people know about them in their own backyards, they can discuss them. Can I lead you off, Nadia, on this? If you have some ideas around that.
Sure. So there are natural history studies that are going on in ALS, right? And so for us to understand why a person is progressing in a specific way, we need to look at large amounts of data, right? So we can't just look at one person with ALS who's progressing slowly and know all of the answers, but the answers are there. So we have to go find them. And that's a difficult thing to do. But the way we do it is by looking at large amounts of data across populations. So ALS TDI has a study called ALS Research Collaborative, where people can participate so that we can understand what is happening in your body over a long term. And then when we start comparing larger amounts of data in people who are progressing slow, for example, versus people who are progressing faster, we might be able to understand some of the things that are happening in somebody. So those studies are out there. People are looking at these things. And I think it's good for people for people with ALS to know that that there are studies that are trying to elucidate these answers.
Does anyone else have any other studies they know in this area? David?
I'll add. So actually, there was a study several years ago that tried to do this and looked at a particular marker, a Belgian study combined with the US, and they found a marker called EPHA4, FA4, that they felt was people who had a loss in the ability of that particular protein to work survived better. So this led to people trying to start to look at whether or not that could be a therapeutic target. And unfortunately, that has had mixed data in the laboratory to date. But I think that really set off this idea in the community. And, as Nadia said, this is something that people do think about. How can you learn from people who are slowly progressing to find targets that could potentially work for people who maybe are progressing more rapidly? And yeah, to echo what she said, I mean, there are so many of these initiatives around the world. Answer ALS, TDI's Precision Medicine Program, and ARC, the Precision ALS program in Europe right now. Australia, Gethin, you have some amazing things in the works. We have Capture ALS in Canada. As we get more and more of that data, more open access around the world, we're going to be able to parse out slower progressors and faster progressors and start to look for those differences. So I think we're on the cusp of that and being able to do that more effectively. And yeah, totally echo what Nadia said. I think we're on our way to really being able to do that in a more effective way.
Yeah, I think perhaps that's something that people aren't aware of, but these large cohort studies are the ideal sort of framework within to compare people who are perhaps different rates of progression and different heterogeneous aspects of disease. They're not always sort of advertised as that, but that's one of the big uses of those studies is fast versus slow progressors. So those studies are certainly underway. We also have a study going on in Australia where we're using really high intensity MRI studies to actually look at the imaging in patients with either fast progressors versus slow progressors. That's a very study looking at precisely that to try and identify difference in brain imaging of patients with different rates of progression. Nicole Kuldip, do you have anything to add to that question?
No, I think this idea of looking at what we call resilient genes, things that increase or lower your risk, I should say, of ALS, MND, if there are people that have the disease but are able to survive it longer. I think Nadia and David talked about different natural history studies where we can start to look at the clinical phenotype and try to tie it to molecular understanding of the disease. So I think this makes sense.
Yeah, I'd echo what you've said there. I mean, Rick Bedlack's looking at some of these possible slowing down, short periods of slowing down in MND as well, and trying to look to see, if there's any genetic or environmental issues with that, or so that's it's being looked at in a few areas.
Right, thank you. We have a question here that's targeted a little bit at Dave Taylor, but I think we all probably have an opinion on this. So why does Dave Taylor disparage the therapy neurone? Is there an agenda here, or perhaps, Dave, you could give us your thoughts on this?
Sure, and thank you for the question. Very briefly, I started off of being an ALS scientist in the lab about 11 years ago, and one of the first things I came across was people really were very excited about this particular therapy, neurone, back 11 years ago, and I got a lot of questions about that. And one of the things I realized very early on was I was in a unique position in my role to have an access to global ALS experts, clinicians, researchers, and how better to use that role than to be able to facilitate trying to provide information that I'm hearing that wouldn't necessarily be out there for the community to be able to access. And so all the way along with all therapies, but including this particular experimental treatment, I have tried to find the most balanced way to be able to provide that information out to the community, because I feel like every person who's newly diagnosed with ALS-MND is going to come online, they're going to come to place, they're going to go to webinars, and they're going to hope that they can get some window into information that they can then make their own decisions upon moving forward. And so it's always come from the compassionate idea of trying to provide information. And so with this one in particular, I ended up going online. I had some wonderful advocates here in Canada from the community who kind of pushed me to go onto Twitter in 2021. And that was soon after the readout of the phase 3 clinical trial for this particular, for neurone. And I had really strived to try to get an opinion from everyone around the community as to how they felt the data, what it was saying, and what were the things that we'd learned over the 10 years of its development, or 10 plus years. And so I'm really trying to provide that information that I'm hearing, that I'm seeing, that I see, and in hopes that we just have a good balanced dialogue for anybody newly diagnosed to come on and really be able to see all aspects of things and try to understand for themselves what, how they want to move forward, and you know, we will see how it comes forward, at least with the FDA, and hopefully we can continue to have balanced and open dialogue on it, because I think it's super important for people in the community, and that's all it really comes down to. So the agenda at the end of the day is just, you know, to hopefully provide good information to people, and yeah, so I'm happy to expand on that if you'd like, but I mean that's sort of where it comes from.
Yeah, I don't think any of us want to see any potential therapy fail. We all want to see them come through with solid evidence backing it up, and get approved and get into treatment. And I'm really happy to see Neuron go to the AdCom and go in front of the FDA. And I hope the FDA look at the data and they feel it's strong and support it, and it gets approved. But that's we should just trust that process, I feel. Anyone else have anything else to add to those comments?
I'd just say, yeah, there is no agenda. We said that before, and that it's good that you know, under considerable pressure, that people are willing to speak out either way, and to have that debate go on. So yeah, I mean, I'd kind of say thanks to you, David, for actually putting yourself out there.
Yeah, and I could add.
Sorry, Kuldip, carry on.
No, go ahead, Gethin, go ahead.
I was just going to say, but one thing I'd really ask for is the debate remains civil. I mean, David's always extremely respectful and considerate in his comments, and there's no need for anyone to come in there with personal comments or disparaging. David does this looking at, and we all do. We all look at the data, and we all try and provide honest advice to our communities. You know, no one's, like I said, no one has an agenda. And there's no need to try and make it personal or start swapping insults on social media or anywhere. That doesn't help anyone or anything. Sorry, Kuldip, carry on.
No, I completely agree, Gethin and Nick. You know, this is no one that has met a person with ALS would, you know, look at treatment landscape and say, gosh, we need treatments and we need cures, and we're all biased. We all want a cure. We want, you know, we want something that can get rid of this god-awful disease. And so you know, if there's any agenda, the agenda is that we want to you know, make this disease a livable disease and find a cure and get rid of it. I think we all as scientists have a responsibility for looking at data and making sure that the science is rigorous, the data are presented in the way that that are not just championing a particular segment of the community, but that you know, here's the data, this is what they mean, this is what we did in the analysis, and here's the full data set. And I think that type of transparency is very helpful. And you saw it, Nadia talked about some of the readouts we've had in the last 4 or 5 months. We have seen some of these companies come out and talk about what worked, what didn't work, what measures you know, met the primary endpoints, the secondary endpoints, and which didn't, and what kind of analysis is happening. I think we need to be prudent. Yes, we're desperate. Yes, we want to find that cure and treatment as soon as possible, but we have to be careful in the way we interpret data. And so, you know, David, thank you for taking that role of providing sound information to the community.
Cool. Because great comments there.
Could I echo just one other last thing really quickly? And I appreciate, I see that Kevin Robinson's also mentioned Nadia in this, because she does a huge lift in this community in terms of providing balanced information across the board, and through Facebook, through her role. And so I would like to echo that. Thank you to our colleague here. Just also adding that, you know, we are also, all of us, we also speak with the companies involved in these situations on a regular basis throughout the clinical development. You know, we are connected in a lot of ways. And so we do actually have really constructive and thoughtful dialogue behind the scenes. And so often what you'll see might be a distillation or like a sort of a summation of the things that we're reading and seeing, and so just so people know where it's coming from, it's really coming from a lot of thoughtful dialogue behind the scenes, and maybe what they're seeing is just a shortened piece of that. But anyways, always welcome the dialogue, and happy to talk about it in more detail off of this so that we can move on. But doors always open for those conversations. Thank you.
Thank you, David.
I just have a short comment. Thank you so much for the kind words, Dave. Approval is it's a nuanced process, right? We've seen a few approvals, since 2017 in the US. Since Radicava, there's been a few other approvals, and there's pieces of each one of those approvals had different highlights, I think. And so it is going to be good to have the public discussion through the AdCom. And I'm grateful for the discourse on both sides, right? It's exactly what everybody has said, that we need balanced views. And it's good to have that, even in places like social media. Social media is here to stay, but we have to be able to have a dialogue. So thank you all for letting me share my thoughts here.
We appreciate them. Okay, moving on to the next question then. This is a sort of a more general question. So is alternative medicine being considered for ALS patients? Is anyone across any alternative treatments, which is in itself is a fairly broad term. So I don't know if anyone has any specific thoughts about this. Kuldip, you're first off the mute.
Yeah, I mean, I think here, Dr. Rick Bedlack, Nick mentioned him earlier, has been at the forefront of this. He has looked at, I'm assuming when alternative medicine is being talked about, I'm assuming that this is, things like nutraceuticals or vitamins or, all, the slew of things that one can try. And Dr. Bedlack has a website, Untangled, ALS Untangled, that, by the way, the ALS Association is funding. And what he does is goes through the data that's available, relates to biology of that alternative treatment to ALS, and then looks at any clinical use of that medication or therapy or alternative approach. And so, if you would like to learn more, I think that is a really good resource to go to. Dr. Bedlack publishes these articles in a year and talks about the type of evidence that is there and the safety issues, if there are any. I think a lot of time with alternative approaches, they may be, we can always try it, but you also have to make sure that it doesn't lead to either faster progression of the disease or cause other complications. And so I think resources like that are really important to go to. But there is funding around alternative approaches. I have seen even at ALS Association, we've funded work in looking at nutraceuticals for ALS in a clinical trial setting. So, thanks for that question.
Yeah, and I think the first thing is a do no harm approach. So you should always discuss it with your treating physician, neurologist, before you contemplate these treatments. I think most alternative medicine treatments are not going to be harmful, but you never know, and it's always best to talk to your neurologist to check it's not going to interfere with any potential drug trials you might be interested in or something like that. David.
I just want to add as well, totally echo what Kuldip and what Gethin have said. I'm going to lower my hand. And just that I think one thing I always like to say as well is if we knew of anything that was an alternative therapy as a community, academics, as well as individuals who work at organizations, we would absolutely tell people, we would trumpet this if we knew that something worked. So, you know, I think that's just one of the things to be a little wary of, and again, speak to your neurologists and your clinicians, because if something sounds really good, if we knew that it was as good as it may say, then we would absolutely want you to have it, because we, as Kuldip said before, we all want, you know, good things for people, and so yeah, just wanted to add that piece. We would definitely tell you.
Yeah, sorry, Gethin, can I add to this? I think David just made a really good point. I actually spoke with the person with ALS, who, this was a couple of years ago, who had gone to Mexico. They lived here in the United States in Florida, and had gone to Mexico and gotten quote unquote stem cell treatments. And these were injected IV. You know, there's no stem cells that go through the blood-brain barrier. So, you know, but, you know, it was one of these things that he heard about, you know, that, you know, someone has a therapy that works against all neurodegenerative diseases. And so they, you know, he went down to Mexico and got, you know, 3 different times, by the way, and got, you know, these treatments given to him. And, you know, when I kind of sat down and explained the science and how this would not work and what, you know, what this means, I think David is right. If there was something like that, it would be out there, and we would be telling you, as scientists, telling you that this works. Please be aware of such type of claims, and do not risk your health and your you know, well-being by participating in these types of just unknown you know, treatments, quote unquote, that may be available. You just please speak to your physician before you do anything like that.
Oh, sorry, Nadia, did you have a comment on that as well?
Yeah, I have a quick comment. Yeah, so I think Dave just put 10 red flags in the chat there. And that is a really helpful article. I talked to a lot of newly diagnosed families who are looking for things. And look, I mean, I went through ALS in my house too. And my husband was a physician who worked in pharma, and we wanted to try things, right? We also tried nutraceuticals, and it's important to do it in a safe way. I mean, those things also have side effects and can cause problems. And we ran into those in my house. So there are smarter ways to do this with a discussion with your doctor and looking out for things. Dr. Bedlack also did a Niels webinar earlier this year where he talked about supplements, and he did a really good job breaking down how to do it. And so it's a good starting point to listen to him and then go to your doctor and have a discussion. You know, I know ALS is dire and that we're looking to try things, but I think there are better approaches to trying things with a discussion with your doctor. And so I just wanted to add that in.
So keeping a little bit with the stem cell thing, we did have a question coming in. So moving away from perhaps the stem cell pseudoscience that's out there, what are the genuine hope around potential stem cell treatments in the future or what have we currently got, and perhaps what is there in the future for stem cells in ALS? If anyone wants to jump on that one. David?
I'm happy to start with it. So I think that you know, one of the things that has always been there for people with stem cells has been this idea of potentially rewiring or repopulating the neurons that we have that degenerate in ALS. And I think even in 2023, that remains something that is very difficult to conceive of, given the complexity of how a motor neuron would be connected from, say, your brain to the tip of your toe, or to, well, a chain of motor neurons in that respect. And I know that there have been some people working on trying to find novel ways to do that, but I don't think that those have come forward yet. As of now, I think we still think of the idea in ALS as stem cells biologically as potentially being supportive systems for the neurons to have a healthier environment surrounding them while the process of the disease happens. And whether or not there is a value of that, we still, I think, have never really had defined evidence of that in any kind of clinical trial to date. There is a core stem clinical trial from South Korea that is going on as another one right now. But in absence of that, I would say we haven't had any to date definitive evidence that can tell us one way or the other whether or not. And I think from the biological aspect, it seems like, you know, something that could potentially slow progression, but we have no evidence of that yet. And I think it would be from that standpoint of supportive health for a motor neuron and the environment around it. But that's my thoughts anyway.
Yeah, I agree. I think yeah, stem cells, true neuronal stem cells, to be able to implant them into people to replace degenerated neurons is the absolute aim. But I don't think we're anywhere near that yet at the moment. I don't think people have managed to do it even in mouse models yet, let alone in the clinic. So I think it's certainly been worked on, and people are doing it in dishes. We can grow neurons in dishes, but we haven't got to the point of transferring it into living animals yet. So unfortunately, I think we're a ways away, but it's certainly something that is being worked on. I don't know if anyone else has got any more specific comments around stem cells.
I'll just say that I don't think if you were to ask the wider scientific community as to whether or not this is like the thing that we're all focused on, I think there are some people interested in this, but I think we're really still focused on the idea that if we treat people early enough and we hit the right target, that actually pharmaceutical or biological intervention within finding the actual target or triggers of ALS. And we've actually had some really exciting things in the past year at the basic research level that have suggested we may someday be able to detect what's happening with ALS in the general population upstream of the symptoms, if we can learn about the biology and the triggers and the signals that are out there. And so if we can do that early enough, we can hit the right targets. Tofersen and the Atlas trial are a great example of, you know, the potential of what we might be able to do. And I think that more people seem to be focused on that than thinking about replacing the neurons. But there's definitely people out there looking at that, but I just didn't want it to feel like that's what we're all striving towards in the field.
No. Yeah, sorry if I gave that impression. No, I think that perhaps Dave's comment then leads us on to perhaps the next question is, how can we increase life expectancy of patients? What is the best approach we have at the moment and perhaps in the near future? Kuldip.
Yeah, and we, as new therapies are coming on board, I think we need to look at the quality of care aspect for people with ALS. And, what I mean by that is we know, and there's been several studies that have shown that multidisciplinary care, where you can get care across the board from a speech therapist, a neurologist, a nurse, a physical therapist, and so on, that multidisciplinary approach in ALS has shown to both increase survival and improve function over time. And this is, this is the one area where I feel we're not looking at in a really systematic way. It's great that we are focused on pharmacological treatments and genetic treatments, and that's great. But for people living with ALS today, we want to make sure that they are aware that, good quality of care, good care is also going to be have an impact on survival and function. I'm happy to announce, in fact, today, the ALS Association is going to launch its first ever RFA, or request for applications, for a funding program on research based on quality of care. And the idea is really how to make, what are the best ways to optimize efficacy, efficiency, and affordability of care. This is really exciting as we get more and more therapies approved, like tofersen and Relyvrio in the last year here in the United States. How are these combination therapies working together? Do people that take Riluzole and Relyvrio together, do they have fewer falls? Or do people that take Relyvrio and Radicava together, do they have less hospitalizations because of fewer pulmonary issues? These types of real-world data is what we need to understand, and then use that evidence to include in our quality of care paradigms. And so I think that is what kind of gets me excited about this whole pursuing quality of care research.
Another thing is to, if whatever treatments are available to you in wherever, what part of the world you are, is to get those treatments, commence those treatments as soon as possible after diagnosis, or as soon as possible in your disease course. I think there was a very good study looking at Riluzole that showed that the earlier patients received it in their disease course, the more effective it was in prolonging survival. So, and that goes the same now for tofersen, Riluzole, etc. So it just highlights the importance of getting better diagnosis as well. So that's a real critical thing, better biomarkers, earlier diagnosis. Sorry, I'm jumped in there. Nick, did you have a comment?
Yeah, thanks. Yeah, so certainly multidisciplinary care is a big factor, and I mentioned those grants that we fund. Amongst those, we have 10 grants that are looking at healthcare aspects, and also in the UK we have NICE, the National Institute for Health and Care Excellence, which reviews the care for different diseases, including MND, ALS, and there's a review ongoing at the moment, a piece of work. So that's taking those anecdotal conversations and the bits of science research and putting it into actual clinical practice for people. So it is a constantly evolving process, improving that multidisciplinary care. And that's, as you said, that is one of the key things that extend survival. Yeah.
And I'll just add that because this is an Alliance webinar, I think we all can continue to think about how to do this globally and to help people in places where care, the infrastructure around multidisciplinary care doesn't exist, and or at least isn't the same as we have in the places that we all work in. And I just want to shout out our colleague Janine Heckman in South Africa, who often pulls us back and reminds us the importance of helping to build that kind of infrastructure for things like multidisciplinary care, which is one of the best proven ways to be able to improve quality of life and extend lifespan in areas around the world. So that's just my Alliance shout out here because of
we are taking that evidence from all around the world as well. We should emphasize that, not just the UK, for that best practice, the benefit of everybody all over the globe with MND. Absolutely.
Well, just taking this a little further, so we've talked about getting treatments into people earlier. What can we do for people who are perhaps more advanced in their disease, such as they're bedridden or they've lost their ability to speak, etc.? What are the best care or treatment models for people in a more advanced state of disease? Any takers on that comment? I mean, I'd say again, the multidisciplinary care is critical there as well. All those allied health practitioners are very, very experienced, such as speech therapists, nutritionists, OTs, etc., physios are very capable in trying to really increase the focus on the quality of life for people who have more advanced disease. I don't know if anyone else has anything else to add there about perhaps what there are, I suspect, certain limitations on some treatments, certainly receiving them through Medicare or subsidized treatments, perhaps in more advanced cases.
Yeah, that's a difficult one. I mean, one of the keys to that is people being treated in their own homes wherever possible. You know, that involves staff. We have a huge, we're very fortunate, a huge, you know, community range of volunteers and staff that are able to do that. Again, that isn't perfect, but you know, that's a really important thing if it can be done for people.
Okay, thank you. Just moving on to another question there. Does anyone want to discuss any specific advances we have in respiratory support? Does anyone have any thoughts there? I certainly know that we have a very strong group in Australia doing research into NIV, non-invasive ventilation, and they're actually looking at the moment and looking to involve AI into working out when is exactly the best times to provide that support and how you can actually integrate the rates of NIV with the breathing of the patient. And so you can actually use that to sort of basically personalize the NIV delivery to specific patients. And we're funding a study at the moment looking into that. So it'll be very exciting how they can improve that. And the second part of it is how to actually improve the uptake of NIV. I don't know what it's like in different countries around the world, but probably I think we only get like a 25% uptake of NIV in Australia. And there's another study that's currently being funded to look how we can improve uptake of NIV in patients earlier. So perhaps you can get that greater benefit and preserve respiratory sort of conditioning and respiratory quality earlier by adopting NIV earlier. Has anyone else got any more comments there?
I'd just add that going along with the multidisciplinary care aspect, that what you've said, I think one of the biggest advancements in terms of providing effective care has been in the past, you know, several, like decade or more, has been the advancements in use and timing of an NIV, and I think there's a lot of studies that have shown this, and that's we continue. I think one of the other pieces I would just add about all of these things is there are awesome people around the world working on every one of these aspects that the questions come in on as their daily focus. They think every day, how can I improve respiratory support for people with ALS? And that's awesome, because those are your champions. If that's your question, those are your champions. They're there. You may not see them, but they're working their butts off to figure out a better day for it. So I wish they could all be on here so you could see how the amazing people working on this disease are around the world.
Definitely. Moving on to some of the questions that we've received tonight. There's a great question here about, are we hindering trial success by screening a heterogeneous cohort group? If so, how can we balance specific cohort groups with sufficient subject enrollment to meet statistical significance?
Is this a place for IL-2 to come on? Nick?
Do you want, David?
Yeah, well, I mean, I think that is something that we're acutely aware of, and the stratification of M&D ALS people in trials is certainly something that's, you know, in focus. And we've seen examples where neurofilament, for example, has been used to stratify people, or people with particular genetic subtype for the lithium trial. You know, so it is something we're aware of and is being used in the analysis. And you know, I think Thurston's really given us hope that the biomarkers can move in some treatments. You know, there's work to be done on that as well. So yeah, that's something that's certainly is being used and will be used more and more going forward. Is that looking at the subtypes of people within the trials and accepting that as a reality in the data? Yeah.
Kuldip?
Yeah, and this is what Nadia and David touched on earlier, the natural history studies that are ongoing, like the precision medicine program or the Answer ALS initiative, is exactly trying to understand sort of that heterogeneity. You know, if you're looking at 1,500 people with ALS, you know, are you able to bucket or somehow look at a particular group and say their ALS is, you know, driven by the mitochondrial, pathway versus someone else's, which is driven by inflammation pathway versus someone else's that's driven by protein handling pathway. And if we can start to even classify the different kinds of ALS, I think Bruce mentioned this earlier, you know, ALS is maybe an umbrella term, and there may be subtypes within that. And perhaps if we can identify the subtypes looking through these natural history studies, we can make it less heterogeneous, because now if you have a mitochondrial targeting drug, you can select or stratify people into your trial that have mitochondrial based ALS. And, you know, that's the dream. We would love to get there and, you know, hope that the millions that are being invested in these natural history studies, that's what we get at the end of it.
Yeah, and that might very well relate, obviously, to the first question we had about the slow progressors versus the fast progressors as well. Different learnings to better define different subsets of ALS and MND, because it is confusing. Those terms are used interchangeably when they probably shouldn't be. But all around the world, and obviously are slow progressors PLS or not is another comment. Just a little bit of a clarification, perhaps from Nick. Can you explain how the experts ALS study differs from the SMART and the Healy trials? It seems to be another sort of platform type trial that's out there.
Yeah. So in summary, we're very fortunate. I think that we've got lots and lots of drugs potentially that we want to try. And we're really looking for the best possible drug, a home run, as it were. So one of the quick ways to screen this, and this is the concept of this idea, is we run a small-ish number of people, say 30 to 50 people with MND, through a trial, given a drug, measure neurofilament levels at the start and afterwards, and look for a significant fall in the level of neurofilament, which indicates, we hope, that the drug is effective and strongly effective. And then those ones which are the most strongest with the greatest effect go on to the phase 3. So rather than starting with a trial, many trials with a small effect, we're trying to narrow down from that group of compounds for the really big hitters that are going to have the most effect. So it's a rapid way of screening, looking at a neurofilament effect to then go on to other trials. If that makes sense, I can try and clarify that.
So would you expect sort of positive treatments from the expert trial to roll into, say, the platform trials such as Healy or SMART, or would they perhaps justify a standalone phase 3 trial at that point? I
think it would roll into the other platform trials. Certainly, the idea is that there will be then additional trials, but we know that we've got something that's engaging targets and having hopefully a very significant effect.
Yeah, that's very exciting as well. I think it's the more trials that go ahead with the strongest evidence is important, I think. A question here about, as obviously we're all still looking for more therapies, and the more therapies we have, the better it can be. Why aren't there rolling grant opportunities? You know, as you roll out of you have some exciting preclinical findings. Should there not be sort of always a funding pot there you can apply to straight away to move on to the next stage, rather than perhaps having to wait for the next funding round, which might be 6 months away, to come around? Perhaps Kuldip as the biggest funder here.
Yeah, I could take this. You know, that would be ideal to have a rolling program, but it's not easy as other funders here can vouch for. A rolling program means that you need to have both an internal staff ready to triage those applications that are coming in, if it's a rolling program every week. And then having to have reviewers that are ready to review those applications on a rolling basis. A lot of times finding independent reviewers who are not conflicted ready, and they have their day jobs. Reviewers are generally people who, are researchers and scientists that have their own labs or are in industry. And so logistically, the rolling program makes it difficult at a funding organization. And this is why funders have deadlines, because then they can plan and coordinate on how to get reviewers and how to triage, a number of applications. I'll give you an example. Last year, across the 6 different funding programs, we saw about 240 applications come in from all over the world. That's a lot of applications, to go through. And so imagine if this was a rolling program, it could get even more difficult. Good news is that there are enough funders in our space with deadlines across the year. So, for United States, for example, you could go to ALS Association, but there are other funders like MDA, Muscular Dystrophy Association, or the Department of Defense ALS Research Program, or NIH. And there are other non-profit organizations that fund ALS MND research. And so, there are deadlines throughout the year. So it's not as if you miss out April 30th, now you have to wait for the next April 30th for all the other applications to get in. That's not the case. Even our own, we launched 8 RFAs this year, and they spanned from a deadline of February 1st to July or August, I think. I forget what the deadline is going to be for the RFA that launches today on quality of care. The point is that this is that there are opportunities for you to apply throughout the year.
Thank you, Kuldip. Yeah, I think that's a really good summary, that even a lot of the organizations now are funding internationally as well. So even if there's not something in the US, even if you're based in the US, there are other organizations internationally that can also possibly fund you. And if your data is good enough, it will be funded. Basically, if the exciting data will always get moved to the next stage. So I think we've gone through all the questions now. We're nearly at the top of the hour. So again, I'd like to thank our audience for firing in so many excellent questions and really challenging us there. I think we've gone right across the breadth from really early stage research right through to clinical care. And I'd just like to pass back now to Jess, who will close off the Q&A session.
Thank you, Gethin. Thank you to all the panelists. On behalf of the Alliance, I want to say thank you to our Scientific Advisory Council and panelists for today's webinar, for all you do throughout the year. The work you do to keep us informed on what is happening in ALS MND research and treatments is so valuable, and we can't thank you enough. Also, a big thank you to our audience for joining us today, and to our sponsor, Biogen. I want to wish you all a great morning, afternoon, or evening, depending on when you're in the world. Thank you very much.
Thanks, Gethin. Thanks, everyone.